Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. Well, thank you for joining us today. On this podcast, we discuss both the challenges and opportunities that come with the clinical care of cancer patients who are facing cardiovascular complications. And I am glad to be joined again by my co-hosts, Dr. Dan Lenahan and Dr. Arjun Ghosh, USA and UK respectively. And we are joined today by another international partner, Dr. James Wilson. James is consultant oncologist in London, former colleague with our co-host Arjun. So James, we're really delighted to have you today. And first time guests, we love to hear just a little bit more about your background, your training, how you got interested in cardio-oncology in particular. So give us a little profile on where you are and what you're doing now and how you got there.
Well, thank you so much for inviting me to be involved. It's a real delight to be able to talk about particularly lung radiotherapy, which is my passion. In fact, I was just reflecting this morning, lung radiotherapy trials often get put on the back burner in terms of publicity and profile, because they're often academic, smaller studies. But I think cardio-oncology and lung radiotherapy is something where the academic lung radiotherapy world is really shining at the moment. It's a really active, vibrant research community. So it's a really exciting time to be a lung radiologist. So I met Arjun when I was at UCLH. So I was a consultant at UCLH and an honorary associate professor at UCL. And in the time that I was working there, we started offering proton beam therapy for lung cancer. Now, the way that the healthcare is funded in the UK, the NHS had very strict criteria about who we could offer proton beam therapy to. And we are able to offer private patients proton beam radiotherapy with strict selection criteria. So my interest in cardio-oncology came from that, because obviously the major organ that we can spare with protons is the heart. So looking at how can we offer this to more patients, right, we need a clinical trial. I need a cardiac sparing clinical trial that looks at protons from a cardiac toxicity point of view and hopefully a survival point of view, and I work backwards from there. And the first paper I came across was from a peer of mine when I was doing my research at the University of Oxford, Suliana Teo. And she came up with a really pragmatic way of working out who's most likely to benefit from proton beam therapy based purely on the anatomical location of lung cancer. So she was able to demonstrate that if you have a tumor, be it the nodal or the primary tumor mass, that extends caudally to the T7 vertebra, then you're likely to get a good cardiac sparing effect of proton beam therapy. Because what I'm aware of, particularly in healthcare systems like ours, Arjun, we're not going to get protons for everybody. We need to be incredibly selective as to who's most likely to benefit. So we've got equitable access to that resource to those most likely to benefit. Because in the UK, we've got 2 proton beam facilities at the moment, one in Manchester, one in London. So if everybody with lung cancer decided that protons were for them, those services would become very, very quickly swamped. So after seeing that, I started looking at the literature further. And then for me, the key paper is from Ann Arbor. So Robert Dess's first order paper, where he did a pooled analysis of a number of radiotherapy trials. And he came up with some another actionable pragmatic trial result that we can perhaps apply to a trial. So he showed that if you've got pre-existing heart disease and a mean heart dose greater than 11 gray, you're more likely to run into bother with a cardiac event in the first 2 years. So that was my starting point. And from there, I came up with a number of different clinical trial ideas. And I spent 2 years writing a protocol, applying for money, and just not getting anywhere. Now, this is a really hard sell for so many reasons, which I'm sure we're going to cover in the course of this conversation. What's your endpoint? How do you know it's going to impact in terms of survival? Does it matter if you get atrial fibrillation after radiotherapy for lung cancer? Is the atrial fibrillation just to signify poor prognosis disease anyway, or some other comorbidity? So, yeah, I felt that that trial needs to happen, but getting the endpoint right is going to be quite challenging. So I took that trial. At the time, we had something called TRAD, which is sort of a peer review workshop for my clinical trial. And I presented a number of planning studies that we'd done, both by using aggressive cardiac sparing photon radiotherapy and also proton beam therapy. I was able to demonstrate that if you apply the results that we're seeing in our cardiac sparing to the published models of cardiac risk, you can see significant benefit for patients. But then the feedback I got from the reviewers was, if you can show that you can do this, why don't you just do it? And is it right to deny patients a treatment that you think is going to spare them cardiac toxicity if you have the means to do it already? And then you're sort of between the devil and the deep blue sea, because you think, well, I can't make a strong application for the National Health Service to offer protons for this patient, but I can't do a trial because so well the benefit's clear. That was the position that I found myself in. So to go back to this, we then looked at our patients at UCLH, and we looked at every patient we've treated with stage 3 lung cancer over a 5-year period. And I just applied those two metrics to our data set. So we looked at those with disease caudal to T7 or not, and we've labeled them as favorable or unfavorable tumor location, and those who had a mean heart dose above or below 11 gray, and whether these patients had pre-existing heart disease or a high Q risk score or not. And the results were really compelling. Yeah, it just convinced me that if I take a pragmatic approach and just look at where the tumor is on a CT scan, which I can do at the tumor board, which I can do in the multidisciplinary team meeting, I can identify those most at risk. So the results of that analysis were that if you had a tumor in an unfavorable location and pre-existing heart disease or a high Q risk score, your chance of being alive in 2 years' time was less than 50%. Conversely, if you had a low Q risk score and no pre-existing heart disease and a tumor in a favorable location, there is a greater than 95% chance that you'd be alive in 2 years. And that's completely independent of tumor grade, biology, stage. I know that I'm just duplicating work that lots of other people do in lots of different ways, but I thought that was a really important result and meant that I had to continue to explore this interest in cardio-oncology. So that's my journey to getting here. And then I started working with Arjun, and we had a number of mutual patients.
Yeah, no, absolutely, James. And it's really interesting to see how different specialties within the oncology domain and the hemato-oncology domain get to cardio-oncology. Sometimes there's a bit of a winding path, but luckily we all kind of get together in the end and we can have those collaborations and the shared patients, as you say. And I think it would be really interesting maybe for our listeners who are, of course, a mixture of cardiologists, oncologists, trainees, nurses, pharmacists, just to understand what do you feel are the main issues from the traditional radiotherapy side to the heart, and also with the proton beam therapy, which of course is your kind of expert area. What should we be looking out for in the immediate setting, and then maybe, of course, in the late effect setting?
Something that non-radiation oncologists often don't get is, if we want to get a curative dose of radiation into a tumor, it's got to get in there somewhere, doesn't it? And radiation travels in straight lines. So if we're getting radiation to a tumor in the center of the body, it has to pass through normal tissue to get to the desired location. Now, even in the course that I've been working in clinical oncology, as we call it in the UK, developments have changed considerably. So when I was a registrar, it was not unusual for people to be receiving 3D conformal radiotherapy. So that's still a CT planned, but static field way of delivering radiotherapy. Then we moved to something called IMRT, where we mold the radiation dose across the radiation beam and often treat in a full arc around the body, which allows us to squeeze the dose in slightly cleverer ways to spare the normal tissues around the tumor radiation dose a little bit. The problem is, if you dumping the dose in one area and you're re-diverting it from somewhere else, you're just going to increase the dose to another part of the body using that sort of approach. So the example I give is at the end of a party when your balloons have deflated somewhat, and you give the balloon a bit of a squeeze on one end and the other half of the balloon inflates. That's what happens when I'm doing a radiotherapy plan. So if I get the ideal radiotherapy plan for my tumor coverage, and then I say to the dosimetrist, look, I really need you to drop the radiation dose to the heart, then I squeeze that dose to another part of the body. So I increase the dose to the normal lung tissue or to the spinal cord or to the esophagus. And then we run into different side effects, different toxicities. And then you're sort of choosing, where do I want to put the risk for this patient? Is it safe for me to aggressively spare the heart using that technology if it means that my mean lung dose or the radiation dose to my normal lung is compromised as a result? And that's the beauty of protons, really. So anybody who doesn't, any non-radiation oncologist listening or any cardiologist, the beauty of protons, in a simple term, is you don't get any exit dose. So if I put a beam of protons going straight into the body, I can predict where the proton is going to stop within the tumor, deposit its dose, cause the DNA damage that we want it to do, and then it doesn't travel further on the other side of the tumor. So if you could be immediate applications for that, and one of the most common indications in my practice for this is for thymoma treatments. So if you've got an anterior mediastinal mass, and I know with a high degree of certainty that I can stop the radiation dose within my target volume and it's not going to travel further into the cardiac tissue behind it as much, then that's a clear indication to protons, for protons to me. And similarly with lung cancers, particularly in the same axial plane as the heart, I think there's clear benefits in cardiac dose reduction by avoiding that exit dose, by using a heavier particle, by using protons. We've got lots of retrospective evidence that this is potentially a benefit, but we don't have the prospective trial data, and I suspect that we're not going to get the prospective trial data. So how we integrate this into standard care treatment algorithms is something we're going to need to discuss as a community.
So, James, I have to say that it's been very impressive to me as a cardiologist taking care of patients with lung cancer that the radiation oncologists have gotten really good about making adjustments. Now, in your case, you're talking about whether you make an adjustment to use proton therapy or not. But the other techniques that you mentioned, the IMRT and the SBRT, in many cases where the cancer is right behind the heart or somewhere near a device or something like that, they feel like they can redirect the beams in such a manner that they would still be able to get effective tumor control. It seems to me that radiation oncology has been really working on all the gymnastics of how they would deliver their therapy. Has that been your observation?
Absolutely. And I don't know if it'd be helpful just to talk a little bit in general terms about the difference between SBRT, or SABR, as we call it in the UK, stereotactic radiotherapy, and more conventional approaches, because sometimes that's not clear to non-radiation oncologists. The beauty of SABR, or SBRT, is that we allow the radiation dose within the target volume, within the tumor, to get really, really hot. No, traditionally, we never used to limit how hot the radiation dose within that tumor would get. Many departments now do set a limit about 130, 140% of the target dose. Whereas when you compare that with conventional approaches, we try to get a really smooth, homogeneous radiation dose across the whole volume. Now, if you think about how the algorithm, the planning algorithm works, if you're saying, look, you can dump as much dose as you like within this target, and I'm not going to penalize the algorithm if it does that, then you get so many more degrees of freedom. So the radiation just drops off really sharply on either side of the tumor. So that means that you can give a really high ablative tumoricidal dose of radiation to a small volume, and then the normal tissues either side of it relatively spared. So SBRT has transformed the non-surgical management of early stage lung cancer. The challenge we have is for the stage 3 patients. So SBRT, SABR is not suitable for stage 3 cancer. You need to go back to that old approach where you're giving the homogeneous dose to a much larger volume. But yeah, I use SABR a lot in my practice. I can't believe that, in fact, I would say SABR is now 80% of my practice because we're detecting much more lung cancers earlier, which is a huge benefit of lung cancer screening. And I quote patients with stage 1 disease, the 90% cure rate with between 1 and 5 outpatient treatments, which is not something that as a medical student or junior doctor I would have ever thought possible with lung cancer. So yeah, radiation for lung cancers among leaps and bounds in the last 2 decades.
Yeah, and I think that the corollary to that is that the manifestations in the cardiac tissues are a lot different now, a lot less than they used to be. I mean, mantle radiation in the past was devastating, and now we don't see those types of complications.
Yeah. And you just reminded me of a patient who I had very recently. And it was heartbreaking, really. I mean, we're learning now in England, or I'm learning as now a full-time private oncologist, the arguments you have to have with insurance companies to access these treatments that you know are going to benefit your patient. So I had a young patient recently, 60, with a stage 3 adenocarcinoma of the lung, and she'd had mantle field radiotherapy 30 years ago. And she'd also had a recent major cardiac event with revascularization here in London. And I could not, for love nor money, get the insurance company to agree to pay for protons for her. And even the proton facility where I went, Protons International London, they said, look, we'll price match protons. We can see this is a benefit to this patient. And the insurance company just would not yield and would not allow me to access protons, but just because it wasn't in her policy. So yeah, we've got a lot of work to do as radiation oncologists to keep teaching the horn and waving the flag for these new technologies and making sure everybody can access them.
James, could I ask, in terms of one of the practical issues that we have with lung radiation and mediastinal radiation is the heart is sometimes involved in some way with the tumor. And one of the common issues that we have from colleagues is what approach do we need to do in terms of monitoring for the heart? Often should we be scanning the heart with echocardiography and all this side, and how often or how much does cardiology need to be involved? So from the oncologist perspective, what are you looking for in terms of reassurance or guidance, and how best can we manage these patients jointly?
So that's the $1 million question, Arjun. How much is too much and how much is not enough for these monitoring? And there are some patients, and unfortunately, I don't have a standard protocol. My standard protocol now is to refer everybody. I don't refer every SABR patient because I think if you've got a peripheral lung lesion, your heart dose is going to be very low. So I don't refer every SABR patient or SBRT patient for a cardiac assessment. But anybody receiving radical radiotherapy, that's curative intent radiotherapy for stage 3 disease, I do involve a cardiologist. I'm really fortunate now. I just work as a private oncologist, so I have no bottleneck in access to an interested cardio-oncologist. I can get the patient seen. With lung cancer, time's of the essence. My patients want to have started treatment yesterday when I meet them in clinic for the first time, and I want them to have started treatment as soon as possible as well. So what do we do? And then I think it's really personalized on the individual risk based on tumor location, particularly people with cardiac involvement. I want them to be monitored probably weekly as a minimum. And I think the thing that we need to remember, though, is and this is me being perhaps pessimistic on my own specialty, I think particularly with protons, we push the cardiac sparing a long way. What we haven't done is we haven't done all the primary prevention work and addressing those risk factors before treatment starts. And I think that's probably where the bulk of the benefit is going to be. I mean, that came out in my data from UCLH. It's actually the previous cardiac events or IQ score that put the people in the highest risk group. And then the location of the tumor pops that risk up even further. There's quite a lot going on for these patients, isn't there? They've just been told they've got lung cancer. I'm going to be starting platinum-based chemotherapy as quickly as I can while I'm planning the radiotherapy. And then to squeeze in, okay, right, now I'm going to address your hypertension. We're going to get you started on an ACE inhibitor, whatever. There's quite a lot of change for them all at once. So then that's where this sort of dual care, and the model I'm trying to move to is having once a week a dual radiation oncology, cardio-oncology clinic where we see these patients together. Because particularly when people are experiencing side effects, and you've introduced a whole new host of medications for their heart, I'm giving them chemo and radiotherapy all at the same time, teasing out what's contributing, what's essential for now, or what's something we can pick up at a later date is something that involves a multidisciplinary discussion.
And I think one of the interesting things about this podcast is that, of course, it does have an international reach and people are listening to it from around the world. So I think one question that probably would be of interest to our listeners is, what do you think the future holds in terms of, you're at the cutting edge with the proton beam therapy, but is there something that's immediately or in the near future going to be coming, which is even more cutting edge, or any new advancements which have an impact on the heart or on the cardio-oncology space? I think our listeners would be very interested to hear your thoughts on that.
I think something that we've never really addressed with lung cancer is the individual radiosensitivity of each tumor. So every patient that I see in my clinic gets given the same radiation dose, and that just can't be right, can it? So we're very good at using next generation sequencing and molecular targeting in the stage 4 setting and increasingly the stage 3 setting with consolidation treatments like osimertinib following chemoradiotherapy for stage 3 lung cancer. But we've never looked at intrinsic radiosensitivity. They're starting to do this in head and neck cancer patients, looking at how HPV relates to outcome and perhaps de-escalating treatment in selected patients there. And I think that's something that I can do to reduce the burden of toxicity on these patients by perhaps identifying probably a small subgroup of patients in which you can dose de-escalate. And then I think the burden of the responsibility, to go back to what we've just been talking about, Arjun, is probably by working closely with cardiologists and saying, who's our most at-risk patients? How can we mitigate that risk before we even turn the beam on?
James, this is awesome. Thank you so much for providing these insights. Obviously, a huge area for cardio-oncology, and we are very grateful for the work you're doing in this space and for sharing your experience with our community. And we definitely look forward to hearing updates on whatever trials you do manage to get through. This is a really exciting area of development. Thank you so much.
Thanks, Stephen.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.